framed the end-of-life care guidelines, extracorporeal lung assist, and simplification of Supreme Court legal procedures for withdrawing and withholding of life support. His areas of interest are end-of-life care, ethics and laws for treatment limitation, respiratory support, and healthcare administration. Today, Sir will be talking about ethics, medical legal issues, and withdrawing and withholding of life support. And he'll be sharing his experiences with all of you. It's my privilege and honor to welcome you, sir, for today's session. And I would also like to inform that participants, due to some unavoidable reasons, Dr. Rajni Surendra Bhatt couldn't join us today. And it will be Dr. Rajkumar, sir, who will be handling the entire session. Thank you, Doctor, for joining us, and I hand over the session to you.
Good evening. So I'll try to share my slides and then start my talk. Wait, yeah, there it is. Is this visible to everyone?
Yes, Doctor.
Are my slides visible?
Yes, sir.
Yes. So we will discuss today these issues in the ICU. What are the ethics of ICU care and what we mean by withdrawal and withholding, and what are the clinical and legal issues relating to EULC. I'll start with a little poem that was published in the Intensive Care Medicine a couple of years ago. So it says, "A letter to my doctors." It's about a premature infant. I was born premature 4 months early. You intubated me, put me on a ventilator because you could. My lungs were weak. You gave me surfactant and waited for them to grow because you could, and so on and so forth. The little baby was put on a ventilator, then underwent a shunt, and so on. So in the end, the questions it puts to the doctors, so to speak, that in the end you had to remove everything. Could you have asked yourself this question, whether it was all worth it before? Because we must ask ourselves this little question. Does "you could" mean that you must? See, very often we mistake the two terms. Could, so many coulds are possible in modern medicine, and these possibilities are ever increasing. But it has to be cast in an ethical framework which makes us ask the question whether we must. Because we know through studies by Ruth Byers et al. in Belgium and in Europe, that at least 23% of patients in the ICU undergo disproportionate, that is excessive care, excessive interventions, and they all die surrounded by these machines. And so death has come to be very dystopic. It's no longer a peaceful end. It is something very dehumanized and cut off.
Sir?
Everybody's collective view of a good death isn't it? If we ask ourselves what is a good death, we would like to be amongst our people whom we love. We would like to have peace. We would like to have freedom from many symptoms. And we would like a more spiritual environment than what we witness day after day in our ICUs for our patients. And most of the deaths appear to be, to those who have access to healthcare, appear to be happening in the ICU. This is the experience in the developed world, and increasingly it's so here. Even those who have partial access or those who can't truly afford, they pinch their pockets and end up like this in the ICU towards their last days. So end-of-life care decision making in the ICU is a very, very important part of our efforts at quality care, of our efforts at improving ICU to a holistic care, to improving oneself as a physician, and to improve the lot of our patients and their families. So these decisions are grounded on the three legs of a stool, each one very pivotal and important. They're grounded on ethical principles, on meeting clinical challenges, and also fulfilling legal requirements. A couple of years ago, this very important, comprehensive document was published by the Lancet Commission on the Value of Death by Libby Salnow et al. It's a vital document to understand the current status of death and its implications in our midst. So death impacts our lives in manifold ways, and the way we are dying in a technologically intensive environment means that many things that we value are being compromised. In fact, there are many socio-economic, cultural, and environmental issues linked with it, even political issues that are impacted by the way we have thoughtlessly allowed deaths to become so unnatural in this world. We need to understand death, dying, and grieving, and we need to appreciate that this has to be managed with skill and understanding and sensitivity, human sensitivities. Of course, it should be ethically grounded and most tested. The ethical framework, ethical understanding, and ethical practice is tested most in this EOLC situation. The quality of death and dying needs attention to all these and more. Communication, palliative care skills. It also needs community participation, as Pallium India has shown, and also national policy determines how well we care for our dying. So I'll address these ethical principles briefly. I'd like to keep this presentation not too long so that you feel free to ask me burning questions and we'll discuss, we'll try to learn together. So we all know the four principles which were first established in 1979 by Beauchamp and Childress. There have been several publications, now it's into the 7th edition. And they form the foundation. There are four principles of autonomy, beneficence, non-beneficence, and distributive justice. Obviously, whole of ethics can't be confined to these four principles, but it's a basic requirement that our decision-making pays attention to these four pillars. Autonomy is a patient right. Right to be respected as a person, not just as a body with a physiological aberration or a disease, and then which translates into the respect to the person means respect to the freedom of choice. And this freedom of choice cannot be exercised unless it's an informed one. So the patient has an implicit right to information, honest, explicit information conveyed with sensitivity and compassion. So this is what autonomy really means. It doesn't just mean taking consent. Okay, that is the culmination of all that has gone into addressing autonomy. Yes, consent is an essential requirement for any procedure, for any decision. However, consent is not just a formality to be fulfilled. It's not just going through the motions. It is actually eliciting what the patient knows, or what the patient wishes or values, and allowing a informed participation in the decision making. So it implies that the doctor-patient relationship is an equal one. We have given up paternalism as past. We were used to the traditional unequal relationship, a superior and inferior relationship, which has fortunately given way to a partnership and equal relationship. And this, the spirit of this term autonomy, we as physicians must pay attention to this power gradient between doctor and patient, consciously reduce the power gradient and come on level ground. And that is essential to build this relationship on trust. Now, the other two, beneficence and non-maleficence, are the duty of care of the physician from ancient history, right from Hippocrates' times, and Dhanvantari times, that we make an unspoken promise of acting in the interest of the patient, to care appropriately at all times, and then to promote, actually stand for the good of the patient, the whole person of the patient, promoting the good. And in modern times, it translates into acting as per the standards of care for that particular clinical circumstance. Our modern evidence-based medicine also obliges us to elicit the values and wishes and then match our decision with the values and wishes. So beneficence not only addresses just the disease condition and the physical condition of the patient, but also the person of the patient. So if you do not care for the values and wishes of the person, you are not truly acting in beneficence. And non-maleficence, of course, emerges from the primary principle of, first of all, doing no harm. But this has to be understood a little deeper. The duty not to do harm doesn't only address effects of risks of it, actually means that we take sufficient care that harm doesn't accrue, and then the harm is reasonable. Harm is not over too much, the risks are not too high. And then it also implies that we don't do harm to the expressed values and wishes of the patient. So this is the proper, complete understanding of this term. And whenever we have a gray area where there could be more harm than we expect, then the potential benefits must outweigh potential harm. That is called the best interest. So one must act in the best interest of the patient. Distributive justice is also something to be understood a little more deeply. It means fairness, non-discrimination. We don't differentiate between patients in terms of any identity, any sort of identity, racial, religious group, caste or class or gender, or any leanings. So sometimes the social uh, distribution of resources, as we found in the pandemic, may seemingly go against the personal autonomy of the patient and personal rights to survival and other things. In those circumstances, one has to have an explicit policy so that there is no agenda-driven uh, distribution of resources. So this being the basic principles um, of Beauchamp and Childress, we must understand that most of our decisions have to be passed through the sieve of these four. And although they cannot be perfect, we have to find a best fit decision, sometimes between even competing principles. Beneficence may seem to be act against autonomy, or beneficence and non-maleficence may be acting against each other. There may be tension between justice and autonomy. So, but we have to negotiate between the four. That's what it means. So decision making is a dynamic process. It is not a mechanical process. What is withdrawal and withholding of life support? For a long time, people confused it with active euthanasia. Obviously, that is completely false. Active euthanasia is, by modern definition, we assist the patient in dying through prescription or administration or facilitating the administration of a lethal drug by a process which involves very careful uh, requirements, and the laws and legislation thereof are available only in a handful of countries and states in the US. So we are not talking about active euthanasia. Withdrawal and withholding are also called passive euthanasia, especially by our law court, Supreme Court. But it's a misleading and outdated term, and it is replaced by terms such as foregoing of life support, or simply as withdrawal and withholding of uh, life supporting interventions. That is FLST or WLST. So you can see that withholding means even before starting a life supporting interventions such as mechanical ventilation or dialysis or ECMO, you do not initiate it. There is a considered decision not to put the patient on this support, having taken a decision by a due process through a shared decision making, and not to initiate this. And withdrawing means having initiated. When we realize it is going nowhere, it's not going to help the patient or do harm in many ways, then we, by a similar process, which we will go into, how we take this decision, we remove that life support. For a long time, we had legal ambiguities which were stopping us from fearlessly taking an ethical decision. A lot of us were still taking these decisions because that is very important if we were to practice intensive care, you know, by the highest standards, but there was always a doubt how the law would view this. Through a long drawn out legal process starting right from 2006 and through Aruna Schonborg case and then through 2018 common cause judgment, we finally came to January 23, where the common cause judgment, wherein it validated Indian citizens' right to execute an advance medical directive and to refuse any sort of treatment, life support or not, as a matter of autonomy and privacy, that is withdrawal and withholding of life support, through a process which was doable and more simplified than laid out in the common cause judgment. So you can see ISCCM, represented by myself, was a petitioner in this case, and we had our legal team. This is our advocate Arvind Datar and Dhwani Mehta, a legal expert. We all worked together, and we had this judgment in our favor. So this enabled us to create a document, a professional statement on end-of-life care, by a joint position statement between the Indian Society of Critical Care Medicine and the Indian Association of Palliative Care. This expert panel of 20 members was led by myself and included a number of expert palliative care specialists, a neurologist, a lawyer, many intensive care specialists, oncologists, anesthesiologists, also ICMR ethics head, also the head of Tata Memorial Cancer Center, a nurse, a palliative care nurse. And this group, through a Delphi process as well as through a thorough systematic review process, we created a document 15 pages long, 50 pages long, having 14 sections about 10 or so tables and a figure, laying out what is the evidence basis for these guidelines and what is the legal position in India. It's a whole chapter on that. And then how the evidence basis clinically and the current ethical basis and the legal basis, how we can crunch them all together in a 10-step EOLC pathway. And I'll go through this one by one so that we can follow this up with a full discussion. There were 3 rounds of a Delphi process where we didn't have clear evidence, but the expert group, through a voting process, through a Delphi process, we created these 12 statements for the Indian practitioner to take to the bedside. And I would like you to address these statements and then see how you relate to them by the bedside. Number 1, quality of dying is as important as other measures of quality of ICU care. Number 2, while discussing transitioning to palliative care, emphasis should be on the patient's suffering. Just on the so far, what has happened is all our discourse all legality. We have taken
Sir,
out. So, tell me.
sir,
Yeah.
your voice is breaking.
Oh, so I,
I think there's an issue with your internet connection, sir. It
severe
is continuously breaking.
irreversible disability, burdensome to the patient. Oh, I'm so sorry. I'll just come out of this and reconnect.
Okay, sir. Maybe.
So I was saying I came to point number 3 of the Delphi agreement acceptance. That severe irreversible disability that may be intolerable to the patient should also come into the discussion. Possibility of this. Am I audible now?
Yes, doctor, you are.
Yeah. So the ICU admission criteria should exclude those cases which are potentially will not benefit from the ICU, or those who have had an end of life discussion and decision prior.
Sir,
And
apologies for
then no
interrupting.
trial of intensive care if again it's
Your voice is
breaking.
breaking once. Yeah, yeah, yeah. Yes,
Oh
sir.
gosh.
Maybe you can switch off your video and continue speaking, sir.
That's right. I'll do that. I'll switch off my video. Yeah. Is it okay now? Am I audible?
Yes, sir. Yes, sir.
Yeah.
Please continue.
Yeah. That's good. That's
Yes,
a
sir,
good
you are.
suggestion. Yeah. Now the uh, so continued intensive care is justifiable only if there is difficulty in symptom control in the ward, or more observations required for adequate symptom control, or if is a there is a potential organ donor there needing support. Now, the intensivist, we have said very clearly with almost unanimous agreement, must take a leadership role in conducting multidisciplinary team meetings. We should not relegate it to the primary physician or other teams. We can take the help of the palliative care teams, and of course, the specialist palliative care team can be part of this team meetings, but the intensivist mustn't really relinquish uh, or abdicate his or her role. Wherever appropriate, the palliative care only option should also be included in the discussion of the possible options. The following roles are appropriate. I mean, it's mentioned several roles. That is, the treating team must initiate the discussions of possible palliative care and what it means. It would provide adequate information for the family to take their own decision and be have an assisting role, and not just present a menu card for people to just choose from, but uh, for genuinely assist in making a decision, and must not impose oneself too much. Allow the family to speak more. So withdrawal and withholding are ethically similarly grounded and are legally equivalent. This we have said very clearly. intensive care professional training should involve right from undergraduate days, and it has listed what all we need to do. Every hospital offering intensive care services must have an end-of-life care policy and standard operating procedure. And it is our job as professionals to spread death literacy and awareness among the public, healthcare administrators, and inform the government. So now I'll come to the heart of the matter in the document, which is the ULC pathway, a 10-step pathway. So this is the overview. I'll take each step one by one. The first step is, obviously, one has to have good clinical acumen and judgment to make a prognostication. We have termed this prognostic assessment as a reflective prognostic assessment. It should not be just a mechanical process. It's a dynamic process in which we ask ourselves some very crucial questions. Whether any intervention we propose would be potentially inappropriate. And in this, we have subjective and objective components. It can't be all objective. Although we have a lot of objective scores, we have general scores, we have disease-specific score, we also have palliative care score. But subjective is definitely an important part of it, which is a very integrative capacity or acumen. And when both are combined, there is a lot of evidence basis to say it is the most effective. That is, we ask ourselves the so-called surprise question. There's a lot of literature, evidence on the role of the surprise question. That is, we ask ourselves, would I be surprised if this patient lives beyond 6 months or say a year? If the answer to this, would I be surprised, is yes, it obviously means that you intuitively feel this patient doesn't have long to live. There are many clinical scenarios which should trigger a discussion on palliative care only option with the family or patient. And we have listed these, and these are all evidence-based again. You can go through the evidence basis. There's a whole section on prognostication in this document. So it may be catastrophic brain injury of any kind, and irreversible or chronic irreversible severe neurological disability. And then superimposed on that, there's critical illness. There's critical illness on a background of chronic irreversible disorders of consciousness, such as dementia, minimally conscious state, a permanent vegetative state, or post-cardiac arrest, anoxic ischemic injury, wherein there is after 3 days, there is a Glasgow motor score is less than 2. So these are also scenarios, and where, having excluded the confounding factors, you must start to talk to the family. Advanced or metastatic malignancy, where it's run its course, the treatment, or the patient has refused treatment. Advanced stage with declining functional status or high frailty scores, or there are repeated admissions to the hospitals. This is another setting. Acute decompensation of chronic end stage organ failure of any kind, again with frequent hospitalization in the last 12 months. Worsening multi-organ failure or SOFA score due to acute conditions refractory to reasonable trial of organ support. They're usually, in maybe 2 weeks' time, this happens in many of the acute conditions as well. Any patient who expresses a desire against aggressive care, either directly or through executing an advanced medical directive, or declines care, that is also a setting. Any other clinical scenario where this answer to the question, the intuitive question, would you be surprised if the patient is alive at the end of 6 months to a year? And the answer is yes. Step number 2 is consensus of assessment by the primary medical board. Now, the Supreme Court has said one must have two medical boards, primary and secondary. Now, willy-nilly in a critical care setting, you have multiple physicians involved in the care of a patient. It may be a primary physician, an intensivist, or any other specialist, maybe a neurologist, maybe an oncologist, maybe a pulmonologist, or a cardiologist. Now, three or more of these can form the primary medical board. The minimal requirements for this board is one primary physician and two subject experts uh, with more than 5 years experience, equal to more than 5 years experience. And the primary medical board can be from the treating team. Primary medical board can be from the same hospital. But if you don't have, then you can invite people from outside. Step 3 is the family meeting. What is the most important crucial intervention in an EOLC decision in the intensive care is the family meeting. Early and as needed multidisciplinary patient-family meetings are the basic to good intensive care on clinical status, prognosis, and therapeutic options, including shift to palliative care only option. Now, this early means what? It should be within 48 hours for any patient, even before it becomes very clear that we are going nowhere and we need to move to palliative care. Even then, at the outset, there should be an early multidisciplinary meeting so that you can get to know the family, you can establish a rapport, and start to build a relationship of trust on which depends all these complex decision making. So you can see that there is a table of how to conduct a family meeting, which is again, it is supported by a lot of literature and evidence, and there's an extensive section on communication and family meetings. So at the outset, you have a suitable meeting place, ensure all relevant people attend, have enough time with minimal interruptions, use vernacular, build a relationship, value and respect the family, take care of non-verbal communication, eye contact, etc. Gather information, connect to the story, talk less, hear out more. Allow expressions of concern, identify and support emotion. Talking freely helps. So, acknowledging emotion, supporting emotion, having sensitive body language, provide information tactfully in non-technical language, provide treatment options, open conversations about the patient as a person and values. Be empathetic, be kind. You know, it is also evidence-based, these points. Convey and discuss uncertainties. Recognize end-of-life needs early. Avoid focusing on numbers and statistics. Outline a plan, making sure it's understood. So how do you ensure that it's understood? You have the ask, tell, ask, technique. That is, at the beginning, at subsequent meetings, and as well as in this one, first ask what they understand, what they know, then clarify what they are unclear about, and then ensure they've understood. Update the status more frequently if things are not going well. Allow expressions of concern. Identify support emotions. Ask, tell, ask again. Summarize and go forward. You can use breaking bad news techniques such as the spikes protocol, and then have a proper EOL discussion and decision making, as which we'll come to. So communication and negotiation is the fourth step, which is also called the shared decision making for treatment limitation. Once it's very clear that curative treatment option is not going to work, we check for the validity of advanced medical directives, if any. Now, this is a minority, but this is going to increase in the days to come with the ease of executing an AMD by the new Supreme Court criteria. Consider patients' directives if there are, and then also work with a surrogate appointed in the AMD, or if it doesn't exist, then work with the family or representative, that you can identify. So goals of care, GOC, has to be set in the best interest by combining the medical recommendations that forms the beneficence and non-maleficence, and patient's choices constitutes the autonomy. Now, communication should be within these descriptions: candid, realistic, respectful, sensitive, and benefits and burdens of each treatment should be properly opened up and discussed. Step 5 is to ensure teamwork. That is, you should debrief your team, including the nurses, including the paramedics, and all the junior physicians who have not had a chance to be present. So if you do that, everybody has a common understanding of what to do, and there is no consensus at this stage between the family and the physicians. Then one should stay any decision until conflict resolution takes place, and you can use second opinions, other opinions, use an ethics board if you have one in the hospital, consult the family physician, or you can take non-medical decision support, such as a family elder, counselor, religious guide, social worker, and we go back to the step 1 of the pathway and reconsider the prognosis and the options. Approval of the secondary medical board. This is again a very crucial step which is prescribed by the Supreme Court, that it wants this decision between the family and the primary board to be validated by a secondary board, which is constituted by, again, 3 members. These members should be different from the first board. There should be a CMO appointed RMP and 2 subject experts of 5 years experience again. But the CMO nominated physician may be from the same hospital. So we have to empanel physicians by the CMO of the district, as we do for a brain death committee, for instance, or a transplant committee. There are no bar on all doctors of both boards being from the same hospital, but we can also invite people from other hospitals. A standing panel of CMO approved physicians may be set up in every hospital. And this is a process. If we embark on this process, there will be great ease of decision making. If the SMB, Secondary Medical Board, approves this, then implement the decision without much ado, with simultaneously informing the district jurisdictional magistrate of the first class. You may electronically make this send this information, but you need no approval. You don't need any approval from any judicial officer. So all these treatment limitation decisions may include a DNAR, do not intubate decision, non-escalation, de-escalation, apart from this, for the classic withdrawal withholding decisions. If there's no approval by the SMB, what is the relief we have? We can resubmit to the SMB with new justification, or approach the clinical ethics committee to resolve the conflict. Or, if, as a last resort, one can directly appeal to the High Court. Anybody can appeal to the High Court who is involved in the decision making. It could be the hospital, it could be the primary physician, it could be the family. Once these decisions are made and implemented, you must take steps to provide holistic care. So address the physical, emotional, spiritual needs of the patient. You can see in this picture how the end of life situation can be quite cheerful. It doesn't have to be morose, and can be in the company of the loved ones, even in a hospital. And you can ensure comfort from symptoms. So one must prioritize a patient's comfort over avoidance of side effects of medication, stop superfluous tests, monitoring, and therapies, liberalize visitation, because so crucial to have family with you. Family needs you and you need the family. Display cultural sensitivity, allow non-intrusive religious rituals, which is so important and emphasized in that Lancet Commission as well. Non-abandonment. One must stop by the patient time to time, have a chat, and have therapeutic conversations. If the patient so desires, transfer to the location of choice. Provide professional caregivers and administrative support if you're an administrator, because professional caregivers can also undergo stress and burnout. And then there is this table where there are symptoms are specified with the appropriate treatment. Please go through it in the main document. And this is just a summary guide and tips. Spiritual needs have also been found to be extremely important in the dying, and there have been systematic studies on this. It is now widely understood that the patients do have great spiritual needs which are unaddressed, and they may look to the physician to elicit them or to address them. And the ISSM IAPC document has suggested a few strategies to address spiritual needs. Open-ended questions in family conferences, focus on humanistic needs that are expressed, active listening to expressions relating to faith and hope, because there could be existential fears, existential apprehensions with the patient. Hearing out empathetically without imposing one's belief, allowing non-intrusive religious rituals, practices such as pujas, mantras, jap, music, prayers, facilitating religious counseling by priests, spiritual persons. Having a quiet room for families, prayer and meditation. Documentation, ASSM IAPC experts suggest documentation throughout all these steps, all the crucial steps of prognostication, of family meetings, of decisions, etc. Documentation with signatures of the parties may be in the case notes or in a form, and model formats are also suggested and are found in the appendices. Grief and bereavement support is extremely important in palliative care because this can be very disabling to the family members. If they call you up and they seek you out for this sort of support, please seize the opportunity and then hear them out and give them the conversation that will prove to be therapeutic. Lastly, review process and quality control should be in place for oversight, conflict resolution, and for protocol renewal and updates. So I would like to end by giving you these take-home key points. The quality of death is an important quality marker of the ICU. This is a very primary message. The competencies needed to achieve this include understanding of ethics, clinical assessment skills, and the current law. Following prognostic awareness, there's prognostic awareness with the treating team and with the family, a shared decision making is arrived at between physicians and the patient directly in a minority of the times, and with the family mostly. Withdrawal and withholding are same ethically and legally. They should be understood, although withdrawal looks more daunting, can be more challenging, may need more care and more documentation. However, once we start doing it, it gets easier and easier, like any procedure in intensive care. The steps of a ULC pathway integrates evidence-based clinical processes with recent guidelines by the Supreme Court and obviously putting everything in the framework of the 4 principles of ethics. Thank you, everyone, for your patient listening.
Thank you, Doctor, for your wonderful session. So I think as of now, we can take questions from participants for the next 7 minutes, and then we can proceed with the case presentation. So participants, I welcome questions from all of you. You can post it in the chat box. I can read it out for Dr. Rajkumar, or else you can
Please do.
Raise your hand and then unmute and ask. So as of now, actually, we do not have any questions in the chat box. Like I had one question coming in my mind. Can I ask
Yes.
that? So
Mm.
what are the challenges that you generally face while you handle these situations? Like for example, we were talking about foregoing life-sustaining treatments. So what are the realistic challenges that we face when we go through all these steps? Based on your experience, if you can add any points on that, it really be helpful.
Yes. Uh, Usually the challenges are less daunting than it appears on the face of it, because they fall very naturally in the course of things in the ICU. When you are faced with something, mostly it's quite clearly the patient has come to the end of the road and terminally ill, because at least half the patients in the ICU these days are elderly with multiple comorbidities and in their last legs, that you can see walking into any ICU in a tertiary care center. So the crucial step is to be able to talk to the family. Okay. Now, talking to the family is an art and science, and the more you do, the easier it will get. Just as initially, getting a venous access or putting a tube looks difficult, but once you do it, then it becomes quicker and quicker, easier and easier. It becomes like a second nature. So I would say that once we start this journey, then the journey itself opens up, ways and means, and gets you to excel. Because for the intensivist, it's very natural to tell the family what he or she thinks, isn't it? And that should be done honestly and bravely. Okay, that is the leap of faith. Okay, you say, I trust this relationship with my family, and I'm going to be honest. Okay, and I will also face whatever questions that come and be patient. Now, I think it's more like a self-education of our how we carry ourselves with the family. That is the biggest challenge. Rest comes easy.
Yes. Thank you so much, sir. There's one more question from Dr. Pooja. So she's asking, who is the person who has to inform the district officer?
Who is the person who has to inform the judicial magistrate?
District officer.
District, yeah. I
I
mean,
mean,
once your
yeah,
decision is made, then an administrator can convey it to the judicial magistrate. It's just like as you notify malaria, or you notify TB, right? So you notify. You're not waiting for any approval. Now, how will you approach the CMO to appoint a member of the secondary board? That is the big question. Now, many people have tried and failed. Now, myself and my colleagues, we have approached the health ministry, and they are working on it, central health ministry, and also individual state health ministries, working with the UP government. Now, I met with the principal secretary, health secretary, and other secretary, additional secretary, and also with the Odisha government, my colleagues have done. and work is going on with Maharashtra government as well. So what I'm saying is this is work in progress, and soon you will suddenly find um, another vista open suddenly. Okay, so that there is information, as the Supreme Court had mentioned in its order, that all the districts must be apprised of the Supreme Court rules in this matter, and they must facilitate, okay, the implementation. Now, this information, see, does not is not being received by many of the High Court registrars. See what I mean? That's where the roadblock is. So we are taking active steps to fill this gap, and this will soon happen. Once this happens, then you will have your district CMO aware of this. You can approach the CMO to appoint doctors in your hospital who can be available. Now, Supreme Court also says it should not take too long. Now, the approval from the secondary medical board should come within 48 hours. Okay, so it is not a long drawn out process as it looks. Okay. The first step, anyway, takes a variable length of time depending on the condition of the patient. But between the first step and the first medical board and the secondary medical board, it can be done very quickly within minutes or within 48 hours. If you have a standing committee, and this can be done, as you take many other board decisions in the hospital.
Okay, sir. So that is one more question from Dr. Jayakumar. If we are not able to convince family for end of life care and family wants full support, but patient has expressed wish for end of life care in the past, what shall we do in this situation?
You see, patients' autonomy is the most important. Family comes secondary. And when it comes to be a conflict between the two, we have to favor the patient. If there is a valid advanced medical directive and you agree that the given situation is applicable, that advanced directive applicable in the given situation, you have to negotiate with the family and fight tooth and nail on behalf of the patient. I'm not saying you have to enter into a conflict, but I'm saying you have to do advocacy for the patient's rights. Okay, that's part of our duty as a physician. So I would stand for my patient in that situation, and I will negotiate vigorously.
Thank you, sir. So I think, sir, right now we can start with the case presentation for today, which is relevant to the topic palliative care in ICU. We have Dr. Uttara Vijayakumar joining us for the case presentation. Dr. Uttara, are you there?
Yes, Dr. Ashmat.
Yes, please proceed.
Good evening, everybody. Is my audio clear?
Yes, Dr. Uttara.
Okay. So, today I'll be presenting a patient who was actually treated by my colleague who I've worked with in the past. So, I have been following this patient up for those few days that she was in and out of the hospital. So this lady, a 55-year-old, she was diagnosed with malignant phyllodes breast with lung and pleural metastasis and respiratory failure. So she presented to the emergency room with progressively increasing breathlessness, chest discomfort, cough, and wheezing over the past 10 days. And she first presented in the month of February this year. This is 2 years after being operated for a phyllodes tumor of the breast. So she was operated on by a general surgeon, and an opinion was sought from the oncology team at the time. But unfortunately, this patient did not follow up with the onco team later on. So on admission, she was found to have a right-sided pleural effusion for which a chest drain was inserted, and a talc pleurodesis was done after confirming that the effusion was malignant. And on the PET CT scan, she had bilateral lung masses. So subsequently, she was seen by the oncologist and given 2 cycles of chemotherapy and then discharged. 2 months later, she again presents with worsening breathlessness, and this time the chest X-ray shows a left-sided large effusion. It was again drained with a chest tube, followed by a talc pleurodesis. At discharge, her room air saturation was 85%, so she was advised to use oxygen at home along with nebulized management. 10 days after this admission, she was brought again to the ER with worsening symptoms. So on arrival, she was conscious oriented, but she was clearly in distress with a room air oxygen saturation of 70% using all her accessory muscles. And her heart rate was 120 per minute, blood pressure 100 by 70. She looked ill nourished and was unable to lie down without any breathlessness. So she was immediately admitted to the intensive care unit and started on non-invasive ventilation and oxygen by non-rebreathing mask intermittently. ABG showed respiratory acidosis, clearly indicating that there was a fatigue setting in. And a repeat PET CT showed an increase in sizes of the lung metastasis. So at this point, it was explained to the patient and the family that the cancer has advanced and is also non-responsive to chemotherapy. So they all came to the difficult decision that it would be best to palliate her symptoms with NIV, NG tube feeds, and something to alleviate her breathlessness. So she was started on an infusion of morphine and midazolam, after which she seemed comfortable. So she was managed on these lines before she succumbed to the illness 2 days after admission. So coming to the psychosocial aspects of this particular patient, so relatively young patient, and the family and the patient was in denial because of the suddenness of the illness after 2 years of reminiscence. And 2 young daughters were unable to see their mother suffering. Patients still left with unfulfilled duties. Daughters' marriages were pending, and the family was although well educated and well placed in the society, they were still unaware of what palliative care actually means, and the guilt of not following up with the oncology team 2 years ago was still being carried along. And so medications, she was started on an infusion of 3 mg per hour of midazolam and 3 mg per hour of morphine. After 2 hours, when she seemed a bit comfortable, she was switched to 1 mg per hour of midazolam and 1 mg per hour of morphine, and along with the oxygen that was going on continuously. The main concerns here was to alleviate the patient's breathlessness and to keep her comfortable at the end of life, because more importantly, the family could not see her suffering any longer. To summarize, this is a 55-year-old lady with malignant phyllodes breast with lung and pleural metastasis, not responding to chemotherapy, and was admitted with respiratory failure. Palliative care was offered to the patient in the ICU after making the family and the patient aware that this is end-stage malignancy and cannot be treated at this point. Morphine and midazolam infusions were commenced and continued till the patient's death. The family could find solace in the lone fact that she died comfortably and that her suffering was addressed effectively in the days leading to her death. So the points to be discussed in this particular case is, although the severity of the disease was explained to the patient and the family at the first presentation itself, they were not mentally ready to accept it, and they wanted the best treatment for her. So they were clearly in denial on her first presentation. And uh, another point is, apart from this particular combination of medications that was used, any other choice or combination that could have been used in this particular situation, probably the mentors can advise on this. And the family was not really willing to keep her at home or at a hospice, because at home they were really frightened to see the state that she was in. And so although she was admitted into a tertiary care center and in one of the top end ICUs with the best critical care team around, nothing was really done with a curative intent. It was all palliative care. So so these are the points that I probably would want the faculty to discuss on. Thank you so much.
Thank you, Dr. Uttara.
That was quite excellent. Good management.
Thank
And
you, sir.
did you take an active, documented decision not to intubate the patient?
Yes, sir. It was documented. After explaining it very clearly that the outcomes are going to be very poor.
No, that's good.
So,
You see, there are 2 points here. You said the family common
Sir, apologies for interrupting you.
stages
Actually,
of
your
grief.
voice is
Okay.
breaking.
Oh. So the Kubler-Ross's stages of grief everybody goes through, that we know. Okay. So from denial to acceptance, there are 5 steps. So we have to be patient and supportive through this process. So that is what I mean by therapeutic conversation. So the intervention required here is therapeutic conversation. We need to talk to the family when they want everything done. I mean, it should not be interpreted to mean they want all the technology. Everything may mean also your attention. So you can ask them quietly, what do you mean by everything? Okay, shall we discuss? Shall we go into it? What it means to do everything? Okay, so it should be a invitation to converse rather than just one way. The invitation to converse itself is therapeutic. So that would be the intervention for the first question. Combination of medication and morphine is the most effective. Of course, you can use multimodal analgesia. And apart from oxygen and BiPAP, if these don't work, you can use fan on the face. Positioning. Okay. Some position may be more comfortable.
Sir, good evening. Just wanted to clear one thing. Is in the secondary medical board, the CMO has to be from government side only, or it can be from
No such specification. The Supreme Court doesn't specify it has to be from a government hospital. It can be from any place, including one's own hospital.
Okay, okay. Thank you.
sir, many a times in India, the question that Dr. Jaikumar had asked, where the patient has expressed a wish to not go with aggressive care, but the family wants everything done for the patient. So many a times this decision is influenced by the financial burden on the family. So the patient decides that it is time to withdraw and not put any more burden on the children or whoever
Yes,
is taking care of them. Decisions, that is one the patient's decision and one the family's decision.
I agree. A lot of this weighs on the patient's mind, that I should not be a burden. That is why conversations are important. Draw these questions out, let them express this, and then see whether these interventions are justified. They are not justified, then you either very reasonably you can negotiate this. Okay, you can tell the family it's not going to work, it may burden the patient. Now focus on the patient rather than finances. Shift the focus to suffering, okay, and how to mitigate suffering rather than talk about, reducing cost. That will come automatically. And similarly, we talk to the patient that certain things are medically not indicated, so you don't have to worry about burdening the family.
Okay, sir. Thank you.
So what
Sir,
I'm saying is don't duck any question. Okay, don't duck any question. Take it head on, and you will be able to produce some ease in the mind of both patient and family.
sir, this advanced medical directives has to be signed by and countersigned by the notarized or a district magistrate or something, or it is
Yes.
only a single patient sign will be enough.
No. It has to be notarized or a gazetted officer's signature. Previously, it had to be signed by the district magistrate. That has been made easier.
Right. Okay. Thank you.
Thank you, Dr. Uttara, for that wonderful case presentation. Are there any more questions from the participant side? Because I couldn't see anything new in the chat box as of now. So meanwhile, I had one question in my mind here. Dr. Uttara was talking about the continuous oxygen that was given for this patient. Is it okay to do that, or maybe if we could have opted for just an oxygen trial, will that be okay in such a patient?
Absolutely okay. See, we need not use any monitors. We don't have to target any oxygen level. If the oxygen helps to mitigate symptoms, it is all right. If it is adding to the burdens, it should be removed. And I remove all oximeters, monitors. They are serving no purpose. I showed you in that picture. Okay, the person is on oxygen, but it seemed to help him. But there are no monitors. I'm not trying to target any oxygen level. And same thing goes for NIV. We don't have to force it on the patient. If it helps reduce the work of breathing, well and good, and the patient also feels okay by it and not claustrophobic. Otherwise, there is no rule to apply anything like that. Sometimes just some table fan across the face is enough. Okay.
Thank you, sir, for that wonderful explanation.
And also your conversation, sitting by the patient. Okay. Your touch, your conversation, your attention, these are more important.
Definitely agree, sir. Are there any more questions? If not, I think we can close for today. If there are no more questions from the participants' end. Thank you so much, sir, for joining us today. So before I close, just one information which I wanted to share is regarding the next session, which is upcoming on June 13th, which is case-based discussion exercise. So for that, I think I had posted the message in the group this afternoon. So we want you all to come up with difficult case scenarios that you have managed in the past or even managing right now, We want you to send just 2 slides of this entire case. One, make it very brief. No need to make it in that long template that we provide you. Just a small PPT with 2 slides on the difficult case scenarios that you have been managing, so that we can take 3 case presentations for the final session that is coming on June 13th by Dr. Rajamayer. So please send it as soon as possible before Monday evening, 4 p.m. With that, I close and I hand over the session to Shri Priya. Thank you.
Thank you, Dr.
Thank you very
Rajamani,
much.
for
Okay,
joining us.
bye-bye, all of you.
Thank you. Thank you, everyone, for joining us. And
Thank you.
hoping to see everyone soon. This is Sripriya, along with Dr. Rajmani and Dr. Hashmat Farhana, signing off from the Tipsy Cohort. Take care, everyone. Stay blessed. Be happy always.
Take care.